So first of all, I'd like to just say good afternoon, and thank you so much for this opportunity to speak to you today on the Joint Concept for Health Services. And when General Robb asked me to speak on this topic, he outlined a few things, questions to answer, and specifically to talk about several things. One, how in my role as the Joint Staff Surgeon, in partnership with the services, OSDHA, with the COCOMs, with all the different stakeholders, how are we moving forward in the future to support the joint force? And again, like you mentioned, the requirements to kind of caveat, to dovetail into what Dr. Smith talked about. He also asked for me to talk a little bit about how to project medical support globally in all environments, especially within the new Joint Force 2020 requirements, in all domains to maintain readiness, and unfortunately in the environment that we have now of fewer resources. The other question, how we, the medical community, nest our resource base our resources based on existing strategies, strategic guidance, and other joint concepts for a comprehensive approach to health services. I'm going to talk a little bit about the other joint concepts that we support in the joint warfight. And so I'd like to spend the next half hour or so just kind of going over these, but I really want to make it a dialogue if that's possible in this venue. I know we've got set time for questions, but if there's any areas that I'm bringing up that anyone wants to kind of ask or expound upon, I'm open to that if that's okay with the moderator.
And we've got a couple of COCOM surgeons in here right now, right?
We do. I see a couple.
Why don't y'all stand up, just so.
Yeah.
1, 2, 3. There you go.
Okay.
Why don't you guys come up? Hey, come on up. Come on up. Come on, I'm in this back of the room stuff. Come on.
Yeah.
No, I'm not kidding. Come on up front. Right here. There we go. There you go. That's right. Feel the love. Come on up here. Because my guess is that this will be a dialogue between the Joint Staff Surgeon and the COCOM surgeons right here. Come on over here. Come on
They're all
over
here. So while we're doing that, I'll show my disclosure. Have no financial relationships to disclose, but I am passionate about the joint concept for health services, but again, I'm not being paid to do so. So this is the agenda I'm going to follow. Again, before we start, dive right into the joint concept, I think it's important to set the stage of, why the joint concept, why we get there. So the glide path, kind of what has happened in the last 10 to 12 years, some of the conceptual drivers, our current state, and again, to answer the question, why establish a joint concept, and then a little bit about the problem statement, and then ways forward. Okay, this is a really busy slide here, and I don't want you to try to read all the little documents there, but I just wanted to kind of walk you through from 2004, kind of to set the stage like I mentioned before. So why do we get to this point? How do we get here? Taking a look back, in 2004, and it's really hard having General Robb sitting here, and Dr. Smith had to leave because my former, both former Joint Staff Surgeons, and he probably lived a lot of this, maybe not back to 2004, but before. But back in 2004, improving the joint warfighter through Joint Force Health Protection Transformation is the document that you see way over to the left. And that's when, in 2004, the DepSecDef actually directed that there is a transformation plan to be developed for Joint Force Health Protection to be not only developed but executed. And the purpose was to advance health service support to future Joint Force commanders of the 21st century. So we wanted to make sure that we had, as the chairman was developing and the new requirements for the Joint Force 2020 were developing, that we as the health system kind of dovetailed and followed along with what our Joint Force was requiring. And so then that led to the, and again, that was signed out again by the vice chairman and Mr. Wolfowitz, who's the DepSecDef at the time, in October of 2004. And then moving to 2006 with the QDR and what came out of the QDR recommendations, roadmap for medical transformation. The purpose of that was to serve as a catalyst to spur innovation and adaptation in the line forces to produce a truly integrated force that has all the attributes that we hear about all the time now: the agility, rapid deployability, more capable against a wider range of threats. And specific to medical, since again, we need to keep up with those that we support, the specific comments that they made about the medical part was new breakthroughs in science, health, and new innovations in prevention and wellness offer the opportunity to develop a 21st century military health system that improves both the health and saves lives and money. Of course, they had to add that there. And as with other areas related to the department, the QDR recommends that aligning medical support with the emerging joint force employment concepts is critical. So they recognize that we are an important enabler and we need to be aligned with them. And they, again, wanted to emphasize agility, flexibility, responsiveness, effectiveness in all domains. So that led, if you look into 2007, the Joint Force Health Protection CONOPS. And this established, you can see under there, those that you can see, there's 3 pillars that were established under there. 1, a healthy and fit force. 2, prevention and protection. And 3, medical and rehabilitative care. And each one of those, all 3 of those together were considered the JF HP CONOPS. And again, that was to describe the broad spectrum of operational medical health services that would be provided in each one of those domains. And again, the whole intent is to protect, to preserve, to improve, conserve, restore our service members in all phases. And it was supposed to involve the entire continuum from accession to a veteran. So basically when they joined our ranks to the point where they transitioned to civilian care. And then in 2008, that was followed by the MHS strategic plan, which again focused on the performance improvement. And a lot of you might have been around during that time with the MHS plan to improve performance, the MHS transformation to align the service medical departments, TMA, uniform services, and then seeking opportunities to affect efficiencies through jointness and interoperability. And then finally, 2010, you see there the Health Readiness CONOPS, and that the Health Readiness CONOPS recognized that the military health enterprise really wasn't functioning as well integrated as it could in the environment, in the joint environment or jointly, because there were multiple opportunities to gain efficiencies and effectiveness as each one of the 3 services worked through their military health, their medical systems. And how do we better integrate that? How do we get those technologies that each one of the services had together? And so then the CONOPS that were formed out of that were the Force Health Protection, so 3 functional areas: Force Health Protection, Health Service Delivery, and then Health System Support. And then that brings us to today when we can talk about now the joint concept for health services. So all that groundwork was laid through all those documents, all the assessments, all the recommendations and recognition that we as a military health system needed to move forward and be more in line with what our line counterparts were, how they were evolving and the way that they were employing their forces. So I want to caveat here too. I mean, this was all good, solid work, and sometimes with the look on the faces of the audience, when people start hearing about joint concepts and joint things, immediately people think of Joint Medical Command and Unified Medical Command and kind of purple merging different services, medical assets and attributes. And I just want to caveat by saying that's not the intent of this. That's not the intent of the joint concept. Maybe some of the defense shields can start lowering and you can hear the rest of the talk, because I know it's sometimes very confusing when you hear of joint concepts. What does this mean for the Title X? What does this mean for the services? And so again, as I walk through this, hopefully you'll understand that it's not an intent to enter into any Title X business of the services, but a more efficient way of identifying what the requirements are for medical above the services. And it actually, when we get to the end of it, hopefully you'll see how it will actually help the services be able to identify requirements to their line to say, hey, here's what the Joint Force 2020, what the chairman, what the COCOMs require of medical, because right now there's nothing that defines that very well. It's all the services bring their own and we kind of sort later. So I just want to make sure that folks understand that that's what the intent of this is with the joint concept.
General Wells, can you put in kind of what I would call an anecdotal, or actually not its current, perspective of what we consider to be a joint requirement is actually not in doctrine. So talk about how medevac, how airvac, how all these things are not a requirement. They're just stuff that services bring to the fight. So if she tells you that story, you'll see why we have to do this, because at some point a service could say, I'm not doing that, because it's not a requirement. So talk about the real application of what we're talking about.
Well, one of this, and I can give general terms because there's classification to it. But for example, there was a a valid requirement from a combatant command for a medical support for the way that they're employing their forces. And when it went through the typical process for force requirement, it was validated. But when it went to the section that assigns the one service or another to fulfill the requirement for medical, all three services were clomid. And it wasn't because there was a lack of desire, because it's not the medical folks who were clomid. It goes through the forces part, so the line part of it. So what they do, they get the requirement, and they look to see where what the capability is in each one of the services. And if it doesn't exist, then it basically says we are not manned, trained, or equipped for that, and it goes back unfilled. We cannot support that requirement. And so just imagine from the line's perspective of they see this, almost $50 billion, health system that we have in our military. And then when they ask for a capability that's validated, and are told none of the three services can fulfill that requirement. And again, so that's just an example. And it's, again, not because there's not a desire, not because there's not, we don't have that capability. It's just not been documented, codified in doctrine, so that the force, the J33 folks can actually look and say, okay, Navy has it, line item, and this is what it's called. Army has it, Air Force has it, or whoever has it. And so that's kind of what the purpose is there's a way to kind of doctrinally define what capabilities, first identify what capabilities are required. So one of the combatant commands said, we have a capability for this type of medical unit. And then we're saying, well, it doesn't exist. And we know, as you know, sir, we can pull things together ad hoc, and that's what we do well. And that's the whole purpose of this, is to turn this from being an ad hoc type of arrangement where all the services bring their medical, assets to bear. And then we have kind of like a sorting party where you bring the hat out. Who's in Gryffindor? So who's got what? And you've got this. Okay, you go over here. And so and again, it works well, but in this new environment where agility, flexibility, adaptability is required, it's going to be very difficult to do that. And so that's why I think we're a victim of our success, because 13 years later, everything looks, it's working very well. And no one is arguing with success. And I want to make sure I also caveat the gains that were made in the 13 years of war, the survivability on the battlefield, all of the lessons learned from our joint trauma, protocols are unparalleled, but we can do it better. And so next time when the call comes up, we don't have time to set it up. We have to be ready to go with this, plug and play. We need this kind of medical capability, and we got it. It's on the plane, ready to go. And we can do that. I mean, we demonstrated that with Ebola, with our 30-member team. I've never seen something come together so quickly, and I'm referring to the 30-member team of 20 nurses, 5 infectious disease doctors, and 5 trainers. All the 3 service deputy surgeon generals got together and said, okay, we'll give you, Navy we'll give you, X number, Air Force X number, Navy X number. But it was because they all got together and in a very collegial way put together this team, sent them to San Antonio with the NORTHCOM surgeon, honchoing all of that. So we can do it, it worked, but there was really nothing that defined how that's done. There was no joint concept for that. There's no requirement for that. It kind of came together. But now there's one, so we'll document that and codify it. So I don't know if that kind of speaks to the example of that.
Also, the fact there are certain things that we assume
Yeah.
are joint requirements, but they're actually service-specific capabilities.
Right.
And so at some point down the road, the service could say, I don't need to do that mission, and then because there's no joint requirement.
Right.
That's what's key right there. That's what helped drive a lot of this right here.
It is. And our J3 actually gave an example of, the J3 says what keeps him up at night. And he gave the example of our global reach, and he used the example of lily pads, because there's lily pads all over the globe that bottom line, allows the ability to get anywhere with the refueling and, basically have global reach around the world. Well, if one service decides who owns that one station because of either resources or whatever reason, we can't sustain this, and they decide we'll pull it away, that's actually, has a detrimental impact on the joint force. It has a detrimental impact on the combatant commands and the National Command Authority to do what they need to do. So that's just one service's and one example of one service's ability based upon it's a service requirement. There's no joint requirement for it, and so why should they sustain it? And so documenting a joint requirement allows you to be able to justify resources to maintain that capability. And I think that's one of the things, if the one takeaway from this is, that's one of the reasons why a joint concept is a good idea. And again, what you see here is the capstone concept of joint operations. There's several of these capstone concepts, and you can see there's 3 of them that are listed there. So the joint operations access concept, the joint concept for entry operations, and rapid aggregation. So these are specific joint concepts that the line has that we as medical providers should make sure that we understand what they are, the requirements for them, because we might need to create force packages to be able to support what's required. The concepts also have, there's several attributes that General Dempsey frequently talks about of what the future, what the joint force 2020 looks like. And he always talks about placing a premium on partnerships. Because he realizes interoperability, we can't be there, we can't do it alone, we don't have the global reach, we don't have the ability to forward station everywhere, and so we have to place premium on partnerships. We have to seize, retain, exploit the initiative, leveraging better integration, and again, we talked a little bit this morning in the groups, in the sessions about interoperability, not only within interagency, but only within the services, but interagency, and also with our coalition and international partners. So the current state of play, what you see here, I mean, there's been advances in medical operations. I've spoken to this a little bit before. A lot of collaboration in the last 13 years. There's really a need to codify that, and we've got our surgeons in the front row who could speak to that 10 times better than I could about what they've seen on the ground, the importance of ensuring that all of these new units, these new processes, these new interactions, these new small organizations, and just the lines of communication and coordination and synchronization that have occurred that need to be codified, so when we have to go somewhere at last notice, then we'll have those codified up front, so we don't have to go back to that. And again, some of these are very, self-evident. The provisions of health services is an inherently complicated task. I mean, you all know that the complexity of what's required now to provide health care, the logistics, the IT support required, the lines of communication and evacuation, all of the coordination that needs to be done. And then also the Defense Health Agency as a combat support agency. What is the role of the DHA as we're bringing the joint concepts, the requirements along? And again, what we've also seen is there is a lack of framework for joint requirements. We kind of spoke to that already, so I won't belabor the point on this one. So then the question is, and I've touched on some of these, why establish a joint concept for health services? Again, not to take away from the services, but to actually delineate what is the unique core competencies and capabilities that each service brings to the fight. So what is unique to the Air Force? What's unique to the Army? What's unique to the Navy? What are these different capabilities that one has that the joint force requires? How do we identify it to make sure that we know that it's there? These new units that have developed and have been created out of the need that was seen in our current operations. So to delineate, to define those, how do we define what they are so we can codify them, get them in doctrine, and so they're visible to the warfighter when they say, hey, when I was stationed in Afghanistan, I remember this unit over here that did this. I need one of those to do that now. And if we don't codify it, then then no one's going to know what he's talking about, because that's not how you do an RFF. Hey, I need one of those thingies I saw in Afghanistan over there in this. I mean, there's a very specific, methodical way, and we need to make sure that we're part of that lexicon so we can be as supportive as we can to those depending upon us. Continuing demand for military responsiveness. I mean, we want it now. Again, our line counterparts are seeing the concerns of supporting the combatant commands. There's only so many things to go around. There's only so many patriots to go around, and each COCOM has a priority. There's only so many, UAVs that can be allocated in different areas. And so the J3 is pulling his hair out all the time, trying to figure out how do we make sure that we meet the demand of all the COCOMs who have valid missions, because they're only asking for support for what they've been asked to do. So how do we distribute that? We're in the same boat in the healthcare. We only have so much, so how do we make sure that we allocate what we have to those who need it? So it's important for us to be efficient and understand what we have, and also identify the requirements. I keep saying that again, identifying requirements so then we can be supported for that. Future operating environment, I mentioned that. Uncertainty is the characteristic of the future environment. No one knows what the future brings. No one knows what the next conflict will require. And so we have to be able to be adaptable and agile to operate in that environment. And quickly shifting missions and declining resources. So those are kind of speak for themselves on those bullets. So this is the joint concept problem and central idea. So I'll just let you take a look at that on what the problem statement is. And for maybe some of those in the corner who can't see it, so bottom line is, how will the DoD health system continue to provide care while minimizing health threats? And when we say minimizing health threats, that's kind of that's preventive piece too. So how do we minimize threats, keep the, for the readiness piece of it, and also minimize threats when our service members are engaged, treating, evacuating in an operational environment. And again, highly distributed operations, and again, the COCOM surgeons here can tell you the distributed operation. If we had PACOM here, he would also say that his AOR, the span of it, some of these expectations that we have in a static warfight are just not possible in the future. And then the central idea to prioritize and sequence healthcare into complementary, interoperable, and scalable force packages supporting globally integrated operations. We have to be able to do that as medical. So this kind of summarizes all of that. So I know it's hard to see, but the top, the red ovals are all the challenges, and some of them, again, are illnesses, distributed operations, wounds, injuries, occupational hazards. So those are all the challenges. And then, of course, the ends, you see what the ends is: a joint force that's able to sustain readiness and to be able to preserve operational capabilities through health threat reduction, patient evacuation, and patient treatment. And then in the ways, you can see the blue ovals, and again, those are all the attributes of the future Joint Force 2020. Again, global agility, small footprint units, to seizing the initiative, integration, flexibility, partnering not only with our interagencies but our international partners, and then and the chairman also talks about placing emphasis on mission command. So again, small footprint units. I just want to bring this up because the days of being able to have the time and the lift to bring a combat support hospital, for example, it takes, if you want to full up 17 C-17s. The time to set that up. I think the days of needing something like that capability immediately, are over for now. I'll never say never because you never know what we're looking at. But so small footprint. So how do we adapt that? How do we adapt what we're used to bringing to the fight? Because we're used to, having all of our stuff. How do we have a different mindset now to scale down to be able to be agile and have these small footprint, because it's hard to do. I know we have with Ford surgical teams, we've cut them down even smaller. How small can we get to provide the capability that the warfighter needs as far forward as possible? And I remember, sir, we talked about the golden hour. It's not so much of a place, but a concept. You know, it's not, you know, getting a person from point A back to something. It's bringing that capability as far forward as possible. So how do we do that? I mean, there's only so much you can really neck down to get to and still have the robust capability to have any impact on saving lives. But I think that's why we have the big brains in the room of thinking of how do we get there, you know, from a whole full-up hospital to something that's, that has that capability. And so then the potential solution space. So just to let you know, the concept, these are the issues that the concepts are examining. And again, it goes back to requirements. Requirements, requirements, requirements. If there's nothing that I've not heard more of since I've been on the joint staff, it's requirements. I mean, I think I hear that word at least 4 or 5 times a day in very different venues, because that's how we're driven, requirement driven. You can't provide forces unless you know what the requirements are to provide them, and to give you the right kind and the right time, and also seeing and to be able to prioritize, because when you've got, you know, multiple combatant commands asking for forces, understanding what the requirements of each are is important, and how well they articulate it. And for us, to be honest with you, I sit on the joint staff, and there's no understanding or no visibility of medical requirements, because we don't have any kind of document that mirrors our line in what we do. And I have a couple backup slides, and what I might do is, we still have some time, flip forward. Well, flip forward just so we can, because I'd like to hear a dialogue more rather than just going over several types of things. Yes, sir.
Ask a question.
Yes, sir.
There's always the dilemma when you're doing this kind of thing of how much to be conceptual and how granular to get. So when I ask a question here, it's one thing to say I want this capability. It's another thing to say I want this capability and I want it limited to this weight and cube, or it's got to be 25% lighter, you know, less weight and cube than that capability is today. I mean, I'm making that up on the fly, but how are you addressing that? Because that's the level of granularity that then will drive the service that has that particular capability to really get it down, to make that agility and so on and so forth. Are you looking at it at that level of granularity, or to kind of drive change in terms of equipping and all that sort of thing?
Not initially, sir, but we're going to get there with that. So the joint concept is the starting point, and I have a backup slide that I'll show you. In fact, if you want to go to that now, it might be. So this is actually. So I want to make sure that I don't miss the point. So there's a joint concept writing team. So going through this whole joint concept process, and I guess this is a good slide to speak to it. Probably one of my favorite slides. And you know, on the joint staff, there's a process for everything. It's a transparent, methodical process, and I really love it because it's, you know, then I can, you know, check the blocks, and my team gave me a little purple star to put, you know, each step along the way. So bottom line, starting on the left, and the way that this works is it starts down at the chairman's vision, it goes up, and then down the green, and then back up the right side. So basically identifying the concept to develop. So bottom line is looking at the chairman's vision and his guidance, this joint staff, this Joint Force 2020, his capstone concept. Team and I asked the question, so would this be, is health services one that would be one to have a joint concept type of thing? Because I said, you know, hey, I want one too. Sounds cool. And so J7, we actually had a meeting with the J7. He had his folks from Suffolk come up, and he actually said, you know, this one is really exciting because everyone, you know, kind of wants to dust something off and call it a joint concept. It's kind of one of those Me Too documents. But he said this has real meat on it because this is a, and I'll go to the next slide. So this is the body of joint concepts. And so you see that there's the joint operating concepts. I don't know if you can see all of them. So there's the different domains that you see that are running. You see the CSDO, all those are different domains, and there are different joint concepts that match up with each of those domains. There's some of the supporting concepts that actually cross all domains. And if you look on if those of you can't see it, for example, integrated air and missile defense crosses all domains. Strategic communication is the last one, all domains. Net-centric, undersea superiority. So you see, these are fairly big concepts. So they were like, medical needs to be here. This is a great concept. You guys cross all domains. And so that was really exciting because it's like, you guys need to be here because you are important, an important enabler. So the fact that we're not on here, there's nothing that really drives all of the things. So you can see what the major lines are. Those that can't see, CS, is cooperative security. The next one is deterrent ops. The third, irregular warfare, major combat ops. I mean, these are like the big hitters, the line folks, and everyone's like, yeah, this is the good stuff. Where's medical? Because what happens is we're always off over here, and so it's like, and one of the senior leaders, line leaders once told me, he says, men are from Mars, women are from Venus, but you medical folks are from Pluto. You guys are out there. I mean, and it was like, they love us. They know that we do good stuff. They know that we save lives, but when we try to articulate requirements and all those things like the big guys do, we're just kind of saying, yeah, we need a lot of stuff. We need this, and they just shake their head and say, they're the Pluto guys again. So as much as we can have a document signed by the chairman, because the chairman will sign this, that says health services is an important supporting concept that is, the depth and detail to multiple joint operating concepts. That's pretty cool. And so that's the purpose of this. So the J7 was excited about it. He was really excited. He brought his person up from Suffolk, and we had another meeting with the team. And so back to this slide. So we started off with in the lower left hand, defining the concept topics. And then we developed a prospectus. Then we have a writing group that's got all three services, all the COCOMs, the DHA, OSDHA, and they're not just medical, they're line folks, so they're all part of the process. And there's visibility and transparency among all. So we've gone through the working group. So we recommended the concept, went before the Joint Concept General Officer Steering Committee who endorsed it. 12 out of 14 concurred. There were 2 that just thought the problem statement needed to be tweaked, provided that feedback, and those 2 said good to go. They provided their feedback, we added it. So basically it's all combatant commands and all services agree with this. So we go up to the guidance piece. It was approved, and the director signed it and directed the J7. We approved the concept. Now you are tasked to write this thing. You will do a joint concept. So it's basically directed now from the director of the joint staff. So we come back down to the bottom, the stakeholders, so bottom line, we're at the JC GOSC. So the second GOSC endorsed it, and now the next step is we're going to the OpSteps tank. So this is where we get, just like our brethren in the line, we are getting the credibility of being seen at the OpSteps tank, that this is a critical enabler, and here are the concepts and requirements. Kind of a long way around, sir, but to get to your question, so once it gets, and the chairman signs it, and then the director approves it, then it goes through the JSIDS process, and that's where you get either the non-material solution or the material, and that's when it gets to, now, in order to meet this requirement, we need this, when we need this. And then there's capabilities-based assessments that go along with that. And so, sorry, a long-winded story, sir, but I think it touches on a couple of points I was going to mention before. But it gets to that granularity, but with the transparency and the involvement of everyone that needs to be involved. So our line sees it, the medical folks see it, the J8 comptroller sees it. And so when they say, gosh, 52 billion, 50 billion, you guys are real expensive. What do we get for that? Especially when 50 billion, and then we've got a validated requirement. You say you're not manned, trained, or equipped in any of the 3 services to do this. And so there's a disconnect. And so when they see this whole process, I think it'll get better visibility and then give us, as the medical personnel, the ability to identify our requirements and get resources without, with the full visibility of our line leadership. Because now we are one of the supporting concepts of multiple, joint operating concepts, and that's a great. I think that's a great end. So I skipped through a few, and I think that pretty much. I think just that one slide talks through what the framework is and what the specifics are. But I'd like to ask now, open it up just more for discussion or questions about the details. I think all of these we kind of talked about, and what the goals were for that. So I'll stop here and see if there's any questions or any comments. If any of my COCOM, and I see Rudy came in as well from Southcom. So any of the COCOM surgeons. If you want to add anything, please feel free to enter in on that.
General?
Yes.
Linda Steele Goodwin, Research Development and Acquisition, Defense Health Agency. My question is, for us to go from, and I'm the S&T Division Chief, for us to go from the S&T world into the advanced development world, we require the capability development document and the needs statement. We don't have those. Now, under the Force Health Protection CONOPS, we have funded through Health Affairs some initial capability development for combat casualty care. But we don't know of the programs that we have. That's healthcare information technology, infectious diseases, combat casualty care, military operational medicine, radiation health, or the rehabilitative medicine. Which one do we put as our priority to move our 6-1 to 6-4 into the 6-5 to 6-7 world? Currently, what's happening is we reprogram the money back into the 6-1 to 6-4 world because that's where everybody's comfortable, because they can't get over that line. There's no documents and no one is stepping up to write them. The current services documents are not adequate because they're not joint. They may be a joint interest stamped on it, but no service other than one service has written it and has actually said, this is the document that we're going to follow, and we're actually going to buy products if it gets developed. So my question is, that's where I'm coming from. For me to move stuff from, Colonel Rasmussen's area into a product that will be used in the field, I can't keep doing non-material solutions. I can't keep doing some more knowledge products, is what we call them, rather than actually having a product that fixes a gap.
Yeah, I get the gist of your question. Thank you for that. And I don't know, this isn't going to fix everything, but I think it's a start between this and then also dovetailing in, I think, the Defense Health Agency as a combat support agency. Some of those shared services, R&D, of the 10, IT, pharmacy, the healthcare benefit, all those, tends to start with. I think that's also a start of trying to get a, we'll call it joint document, but something that's other than, in one area to the other. So this is more of a, at the strategic level, here are the requirements, and so that the services each can, identify the requirements, because they say, here's what the requirement is overall. And then the services can go back and say, okay, we're on the hook for the joint world to provide these medical and these medically related assets. And so then I think that's more of a, a starting point for the requirements. So getting down into that part, I don't know if I could answer that part of the question, but I know in the R&D section or the directorate of the DHA might be able to.
Go slide 10, last bullet.
Because we're currently.
Which one?
10.
Which
So,
one?
yeah, if we go back to slide 10.
Yeah, because we're currently working off the Force Health Protection CONOPS, which was published in 2011.
So
So go back to slide 10, if we can go back.
I've got the slide.
There it is.
Yeah.
So, slide 10, the last bullet. There we go. Okay, so that I think that's a chasm that you're talking about there, General West, and then you're seeing the R&D community say it says who, and so I think that is really that's a powerful statement down there. We never had an entity that jointly would be what I call help steering that ship from that sat at the apex of the three services that had the authorities to do that. When I say the authorities, the ability to prioritize and shift towards priorities and requirements. And so I talk about the joint first solution where it makes sense.
Right.
Okay, where it makes sense. And before the communities would get together, mutually agree on something, and then they would go back, and then their services may or may not decide to go by the same thing, or may not decide to prioritize it in the same manner because they had other things that, that they wanted to do it, but they didn't make the cut. So now this is going to allow us to say, hey, and I keep going back to the JFAC, the Joint First Aid Kit. People don't understand the importance of the JFAC. It's something very simple, but it shows that if we work at it hard enough, okay, you talk about the continuum of care, from pre-hospital, hospital to en route care, that we have now decided on a joint first aid kit that has the ability to provide care to the TCCC standards, okay, from a joint environment. And then what will happen from the DHA perspective is the services will say, hey, we have an emerging requirement, we'll push it up either mainly through the governance, but also through the logistics channels, so that we end up keeping that currently up to date to meet the requirements for TCCC. That's just a start. Now, that's just the beginning, and you can see the potential across the board. Now, to go back to your point, what's going to happen now, all right, with the Defense Health Agency RDA director, who now, the difference is those JPCs now report to a joint lead, okay? And so when you start looking at a shrinking budget, you start looking at prioritizations, you start looking at the makes per buy. He's the one that's going to have to broker the deals, okay, through the governance process with the services, but before we didn't have anybody to do that. And so it's not perfect, okay, but we're going to take our lead off the requirements, and that's why in the Defense Health Agency, when you look at policy, you look at FHP&R, their workers, the execution piece that sits in the DHA. So we're all linked now in a manner that we've never been linked before. And again, with the joint staff helping drive the requirements, all right, feedback from the guys on the front row, okay, and then working our way back through the processes for your world through the RDA director, which we never had before.
Right.
Thank you, ma'am. Thank you.
Thanks. Yeah, and as you were saying, sir, again, requirements, driving those because, and it goes back to what Dr. Smith was saying. So we talk about making sure we have our readiness platforms and, our, how many surgeons do you need? How many surgeons do we need? We really need to have a hard look at what do we need if we're going to conform the way we deliver medicine to the line that we support. Maybe we need more because we need to disperse them out. Does having MTF based, or do we have all these areas, these pre-positioned, forward deployed platforms? Because how are we going to get to all the hinterlands and Captain Weiss's area in AFRICOM? I mean, we've got folks all over the place, and the golden hour rule doesn't exist. To say that we're going to, pick someone up that's injured out where they operate and then get them back to a level 2 in 60 minutes is not practical, and in PACOM and AOR. But
That's why you need damage control resuscitation as far forward as you can. Stand that golden hour.
Yeah.
First of all, General West, I just want to say, you had me at hello when you started speaking today, and I think there's, amongst the COCOMs, there's certainly COCOMs with a lot of allocated forces, and there's COCOMs without, and so we call them happy com, sad com kind of thing. But I think that this for us really is an important initiative for the future, and I think it will help better define requirements in the future, and particularly as Oconus folks, there's a steady drawdown. If that trend continues, I think will be relevant to just about everybody. So thank you very much for taking this on, and I definitely applaud the initiative, so thank you.
Hey, thanks, Dave, appreciate it.
Because what we've done in the past, and we've been successful, but I think we've also been lucky, okay, is because we didn't have this, all right? But I think what this, the good news, bad news is we're at war for 10 years plus. The good news is we award 10 years plus, and we'll be able to refined to a fine art, the way we've woven the individual capabilities of the services together into a smooth, what appears to be to the line, okay, almost an uninterrupted flow of patient care from point of injury back to polytrauma and rehab, okay? There's a lot of smoke and mirrors there, but we did it, okay? But there's no true requirement to do that, okay? We just did it. And what these guys realized when I set up on the staff, and then again, General West said her staff came to us and said, hey, we got to write this down before we forget it, because when we start getting to, we're fighting with, with all these major weapon systems, with major stuff, and they're going to say, well, where's the requirement? I mean, technically, a service could drop their capability because there's no requirement. And we wove them so together seamlessly that people think it's an integrated requirement that has existed for years. But you got the joint trauma system guys who really drove that seamless transition from point of injury to polytrauma rehab. And these guys' responsibility to say, we got to get into the doctrine so that this is where we're doing business. So that and again, now the line looks and says, why do you need the money? No, oh my God, you come across all domains. Okay? Yeah. Before it was like, says who? That's what says who. So good on you for that. Good on you for that.
Any questions? Yeah, Rudy.
And one thing I would encourage is we don't have enough resources to cover all the requirements. And my experience when I was in Iraq and Afghanistan was the importance of coalition, and Matt can testify to that, where it didn't matter whether it was the Germans, the British, or the Dutch picking you up or moving you to a Spanish hospital. It didn't matter, but we need forums to continue to capture those lessons. Because I'm kind of looking at it in the South Carolina OR as sort of that bridge, some of those gaps that we have, developing interoperability at the coalition level, so that if we should have a contingency outcome, even though we might not have everything we need in DOT to support, and I'm one of the sad towns, although we're not, we can rely on coalition. So that's my own statement there, sir.
Well, then speaking of coalition, I'm not going to put them on the spot, but we got our colleagues there from Deutschland in the back. But, this is precisely what NATO, and General West can talk about this because she's living the dream with what the concept are called smart defense, which is a modular approach to providing a capability. And that's really, if you read between the lines up there, that's what she's referring to. It's a scalable, modular build that nests to a capability. So the core of a 300 or 200 bed theater hospital is still a 5-person, what we call an MFAST, a mobile forward surgical team. Now, mobile forward surgical team is a nest or the initial laydown for an EMEDS basic, which is a nest for a 10 bed, 25 bed, 100 bed, 200 bed. And again, the NATO guys are also, in fact, I'm not going to put you on the spot, but I will. But,
You're not, but you will.
But I will. But talk a little bit maybe about, I don't know how much you guys are versed in it, but also smart defense. But General West, we're glad to help you out because she's living that dream right now at COMEDS.
Yeah. No, and I go back to the slide, because just as you said, sir, if you look down at means, that whole thing, that scalable force package, and again, back to the bubbles, the partnership piece, the chairman always states, and it's in his capstone concept for joint operations, and it's Googleable, it's not anything that's in the, and I would encourage you all to read that, because it's about 18 pages, and there's a lot of pictures, and so, and I always do that, I count the number of pictures and then try to estimate how many pages would it actually be, because, more pictures is better, and so it's very well done, and he has the attributes, and placing a premium on partnerships is one of the things that he has in writing as his one of his attributes of the joint force of 2020. You have to be agile, adaptable, but placing a premium, and not only on interagency, but our coalition, our international partners. And that's what he's, so everything that the COCOMs do in their mill-to-mill and their partner building, their capacity building ops is helping get to that end. So appreciate, thanks Rudy for
And
bringing that
remember,
up.
the German theater hospital comes with a beer garden, okay?
You're messed up.
Am I right? Well, the Sunshine Bar, I was there, I don't know.
You're a mess. Any other comments or questions? Really, it's, or feedback or thoughts or things that we need to, but again, like I said, I appreciate all the services are represented and have sent really good reps for that and really good feedback to get this right. Because It's, we have to get it right. You know, you mentioned decreased resources, you know, I know it's, you talk about happy com, sad com. I think there was a last tank where they all came out as sad coms, because I think the chairman, even the chairman says, hey, you know, we gave an example, we've been kind of punting down the road because we're mortgaging our future, because you know, it's kind of the whole readiness risk balance. You know, we mortgage our readiness to make sure we have enough assets, and so we're breaking down certain career fields because people are just rotating out there so much, because we can't bring them back in and give them a break because there's a need for them. And so he said, we've got to really relook this. We're going to have decreased resources, no joke. I mean, it's, you know, understand we're asking you guys to do a lot. And he gave an example of, you know, I can't use that example, but there is a certain example of certain COCOMs needing, you know, multiple millions, hundreds of millions of dollars for a, you know, a justifiable mission, but then the next one needs 260 million to do this, and then the next one needs, and then after you add it all up, you know, there's negative numbers in front of what's
They
left.
just shot the DHA savings over the next
Yeah.
5 years.
And so there's going to be a kind of a paradigm shift of how do we do it better. And so we as the military medical need to really come along and fix it, or it'll be fixed for us. Because you always hear it, gosh, you know, 10% of the budget, you know, and then they don't know what we do. And so I think this will at least give them visibility of all the domains that we cross and what we cover. But then if we're doing things not as smartly as we can, that won't help us. So as much as we can do to identify capabilities that we don't need anymore and maybe repurpose them, you know, or things that we don't have out there, and our R&D folks are saying, yeah, we need to do this, and this is a capability we need for the future. So appreciate that. Anything else? Any other
Time
comments?
for one more.
Hey.
Yes, ma'am. Was interested.
By the way, the newly
come.
appointed Education and Training Director,
All right.
Defense Health
So
Agency.
I have a training question, but thinking about, and maybe I should give my
Oh,
thinking about enlisted medical training. When we try to consolidate for a particular specialty, you name it, each service sometimes does it differently because there's no joint requirement. And I don't know if this new document will set the bar at that level so that potentially if you have two services that might be functioning in one way, a third says, that's not the way we do it in our service, there's no requirement, therefore there's pushback to consolidate so that you're training it one way, thinking that, you know, you don't know if someone's going to deploy and have to be at some theater hospital and potentially support.
yeah, very good question. And again, this document doesn't get to that granularity, but a byproduct of it is if this is a requirement, and then when it goes down into that lane that I was talking with General Farmer on, when you get into the implementation piece, so the implementation of the approved concepts, again, when it gets to the JROC, this is when you start getting down on the right side, you know, there's a material focus, but then there's also doctrinal change focus, so there's a material, non-material solution. And so those are basically the .mil PF change requests, and so that will get into that based upon the requirement. Then that's when that will kick in if there's any policy changes that are required based upon the requirements. And so, but then at that level, that's where all the services, and usually goes to the tank. So this is a transparent process where you've got all the services, COCOMs involved to say, okay, here's what the requirement is, here's what the training is. But I think, so it will get there, it will drive it, but it's not going to be that prescriptive. I think some of these solutions make themselves evident based upon what the requirements are. And when you're that blue box in the far right of the non-material solutions.
I think even if there's a general statement that said, this should be the goal where it makes sense, but it was written somewhere that, you know, jointness when training is involved makes sense. And on the sidebar, does the new document stipulate where the SG sits in a joint staff?
No. You mean as far as, no, it doesn't really get into it won't tell you the organization in this, at this level, so the concept won't, but when you start getting in the implementation piece, that's when all the discussion of, but they're not gonna, and that's why it's one, to make sure that the services aren't concerned that we're getting into Title X business, because you cross the line, and the chairman is the first one to say, he goes, I own no forces, and I'm the commander of no one. But his influence is from his convening authority of the Joint Chiefs and the COCOMs. And he'll be the first to say, and if you know Chairman Dempsey, he's very colorful in his language sometimes, but he'll tell you what happens if the services think that he's getting into their Title X realm. So that's not, we don't want to make sure that we're not trying to tell the services you can or you can't do that. It's basically saying, I don't know who's going to do it, don't care who does it, but this is what we need. So if you've got it, send it. If you don't, somebody figure it out and make it, and we'll resource you for it. And so that's kind of the tenor of that, not to tell services, but that's kind of where we are. But for the training piece, and I know for our, and I always tell my staff, I really like the organization of the joint concept. For me, I'm like one of those folks that needed the granimals, that link up stuff. I really like these because I really love this because I know where we are on it. And so everything that we do, I try to put it in the line terms, like the joint training. So we have this joint staff leaders course. So it went through the J7, got approved in the same thing that all the other real military stuff gets approved. And so I'm using the same processes to say, okay, this is the curriculum's approved, all that stuff. So they see, and it gives them visibility of what we're doing, and it also makes sure that we have a honest broker, because the J7, they're just like, okay, whatever. They don't have a dog in the hunt, so to speak. They just want to make sure it's doctrinally correct and it has all the things that meet the requirements for the joint force. And so that's why I really like the process, because then it takes the emotion, it takes the, maybe I have a utopian view of it, but I've seen it work to the point where it's, takes the emotion out of it, and it just, it is what it is. And it's because you've got transparency. I mean, you've got these documents that has all the comments. If you look at the JSIDs, everyone who makes a comment, it goes in this huge comment matrix, and anyone that's got KMDS can go into it and take a look at the comments. And so it's none of this cloak and dagger type thing. And so as much as we can get into that, and as much as our training programs, to link up with what our line counterparts do, I think will serve us quite well. But the training piece, that's a good question. And back to you, where the joint surgeons should reside. I mean, this, under the J4 versus, should you be special staff, should you not? So then the question is if you're, I think if you're one of these things, I think it kind of gives, because where's the joint logistics enterprise? I mean, the joint logistics is in the, upper left there, but, I think it raises the level of importance of the staff section of the medical, and I think that's my goal. This will be after I leave, so it's not going to impact what my position is. But I think as long as medical, I think once we get medical in there in the a chairman signed document, and we're part of the body of the whole joint concept structure, I think that'll give credence to that position there.
All right, thank you very much, appreciate it.
Thanks for your attention, appreciate it.